This is a male, 74 years old, with the risk factors of hyperlipidemia, family history of coronary artery disease, diabetes mellitus type 2. His physical examination, he had a BMI of 25.4, a creatinine clearance of 38 with a creatinine of 1.55, a left ventricular ejection fraction of 50% without any wall motion abnormality. The clinical presentation was stable angina class 2. So that was the clinical information for both heart team. At this moment, I will ask the heart team of the UC Brussels to please monitor yourself and put the headsets. We're going to present one of the images modality to the Monsignor heart team.
No peeking.
Very good. Okay, so let's start with the presentation of the CT images. So this CT was acquired, as the professor mentioned, with a Revolution CT scanner from GE. The CT was acquired with 49 bits per minute. Nitroglycerin and beta blockers were used prior to the image acquisition with 50 ml of contrast. The radiation dose with this scanner was 0.9 millisievert. So if we start assessing the 3D vascular tree, we use a projection called 3D maximum intensity projection. We can already see the calcification in the aorta, and if we move on to the coronary vessel, we're going to see a calcified plaque in the proximal part of the LAD, followed by an obstructive lesion in the mid portion of the LAD. While the image is rotating, you will start to notice a lesion in the bifurcation with the first obtuse marginal on the circumflex, which seems to be an obstructive lesion. And if we rotate even more these images, we will start seeing the RCA. You will start seeing a proximal plaque in the RCA. And if we rotate the image a little bit more, we're going to see something at the ostium of the RCA. This is an overview of the 3D mid image of this patient, but we're going to go now vessel by vessel to show the detailed analysis of this case. So this is the multiplanar reconstruction, or MPR images of the right coronary artery. We can see there is something in the ostium. It looks like an obstructive lesion in the ostium of the RCA, followed by a lesion which seems more than 50% in the proximal part of the RCA as well. If we use this actual reconstruction to understand a little bit more what is in the ostium of the RCA, we'll see there seems to be an obstructive lesion in the ostium of the RCA. For this case, we scored 2 lesions in the RCA of the syntax score, 1 lesion for 3 points at the ostium and another lesion of 2 points in the proximal part of the RCA. Moving on to the left coronary system, we're going to see that this patient had a very short left main. You can see here a very short left main. This is the circumflex, and we're going to focus on the LAD. The LAD has a long calcified plaque, which has an obstructive part, which is in the proximal part of the LAD, followed by a severe narrowing in the mid portion of the vessel. These 2 lesions were scored in the anatomical syntax score for 5-point approximate lesion and 6 points for the second lesion. If we move on to the circumflex, we're going to see there is a severe lesion at the bifurcation with the first obtuse marginal and the circumflex, which is very clear in this MPR image. It was scored in the syntax score as a bifurcation Medina class 111 for an additional 8 points. If we recapitulate all the points that were scored in the syntax score, we came up with a total of 24 points for the anatomical syntax score of this patient. Moving on, we also have the functionality of these lesions. Then we start looking at the FFR-CT of all the lesions that we just mentioned. And as you can see, this FFR-CT model is color-coded in a way that everything, all the FFR that is below 0.7 is color-coded as red, and everything that is above 0.9, it's blue. If we go again vessel by vessel, and then we're going to start calculating the functional syntax score, we see that in fact in the FFR-CT model there are 2 lesions in the RCA, one at the ostium of the vessel and one in the proximal part. However, these lesions do not produce an important drop in the FFR-CT. The FFR-CT in the distal part of the vessel is above 0.8. Therefore, for the calculation of the syntax score, for the functional syntax score, we remove the points that were scored in the anatomical score. Conversely, if we look now at the LAD, we're going to see that the 2 lesions that were scored in the anatomical syntax score have some functional repercussion, and the FFR-CT in the distal part of the vessel is 0.61. And there's an important drop in the FFR-CT in this vessel. Both lesions remain for the calculation of the functional syntax score. This is the same scenario as the circumflex, where the tight bifurcation in the proximal part of the circumflex also creates an important drop in the FFR-CT, and the 8 points remain for the functional syntax score calculation. Just to summarize the information of the functional syntax score, we initially had 24 points for the anatomical score. Now that it was reduced to 19 points. We're going to take this functional syntax score to calculate the syntax score 2. Just to remind you, the variables that we put in the calculator of the syntax score 2 is the functional syntax score, the age, and the comorbidities shown in the slide. The predicted mortality for these patients, if it goes for PCI, is 13.6%, and the predicted mortality for surgery is similar, 11.6%. The treatment recommendation equipoise between surgery and PCI. At this moment, the Central Cardiological Monsino Heart team has seen the CT images. I would like to have their decision in terms of what's the best treatment for this patient.
And in the meantime, we were supposed to vote electronically, but that will take a little bit more time now. So the people who are in favor of PCI, yes, please show your yes. That's a big majority. Who is in favor of bypass surgery? Yes for bypass surgery. 1, 2, 3, maybe 4. People said, I need an angio. I cannot work with this multi-slide CT scan. That's flashy, catchy, but I need something else. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Not bad. And who are the guys who said, I don't know? Yes, I don't know. They all know. Okay, that's good.
Okay, Professor Pompilio, if I may ask, what is the decision of Monsino in this case?
So the Monsino final heart team decision is CABG, with 2 grafts placed on LAD and obtuse margin.
So I'm going to interrupt the hypnosis of this guy because they are completely separate, so you can move. Hello. You can move. Yeah, really out of the world. Oh, you're jet lagged. You were sleeping in the meantime. Thank you.
Okay, now we're going to show the angiogram of these patients. So I will ask now the Monsino Heart team to please blindfold yourself and put up the headsets. So be blinded for the angio. Alright, so we're going to start to show now the angiogram of this patient. So let's start with the right coronary artery. I'm going to remind you the heart team of UC Brussels. That is a male, 74 years old, diabetic, moderate ventricular ejection fraction dysfunction, and a moderate renal dysfunction. You can see here the RCA. In the angiogram, we have a lesion in the proximal part of the RCA, which was judged to be more than 50% stenosis. Therefore, it was scored for the anatomical syntax score as 2 points. Moving on to the LAD, you can see there is a long LAD. The contrast is going to the circumflex, a very short left main, but we can identify a long lesion in the mid portion of the LAD. This lesion was scored as involving the third diagonal branch, therefore it was scored as a Medina classification 010 for 7 points in the angiographic syntax score. And if we see now the bifurcation in the circumflex, there is a very severe lesion with a bifurcation with the first obtuse marginal. It was scored as a Medina 111 for an additional 11 points. If we summarize the syntax score of this patient, we're going to see there is 20 points for the angiographic derived syntax score. And if we use this angio-derived syntax score to calculate the syntax score 2, we're going to see that there is a predicted mortality for PCI of 13.9% and 11.6% for surgery. The syntax score 2 equipoise between surgery and PCI for this patient. At this moment, with the information of the angio, I would like to ask the heart team of UC Brussels to make a decision in terms of what is the best option for this patient.
And while they are providing the answer, we will again interrogate the audience after this conventional cine angiography. Who is in favor of PCI? Please raise yes in favor of PCI. Maybe a little bit less than the first time, but very similar. Who is in favor of bypass surgery? That's really a minority. I think it's a Congress of Interventional Cardiologists. So the next question is, who need an FFR-IFR to take a decision? That's a few of them. I mean, certainly one third. Very good. We continue.
So the decision of the Brussels heart team.
So regarding all the information available, so the angio, we would decide for a cabbage, regardless of the interventional cardiologist in the room, and we would go for so the LED, of course, for the memory, and then a bypass on the OM.
Very nice. So at this time, please let know the heart team of Monsino that they can remove the headset, please.
Have to shake them. Will not work, sorry. So, you will show something more. The pictures will go on, and based on conventional angiography, the heart team of Brussels has decided to proceed with cabbage. In a short statement, could you, your own song, the interventional cardiologist, on behalf of the heart team, give the key argument for going to surgery? You have about 1.5 minutes, and in the meantime, the radiologist, John May, will look at the pictures.
Okay, thank you. Well, let's focus first on the clinical characteristics of the patient. 74 years old, diabetic, multi-vessel disease, slightly reduced renal function and left ventricular ejection fraction. Probably slightly more in favor of cabbage for us. In an anatomical point of view, so angiographically, I'd say we have our doubts on the proximal right. It's a moderate lesion on angio, and I would challenge this lesion by FFR if I wouldn't have my upfront FFR-CT as I'm used to nowadays. In the LAD, it's more clear for us. It's a long lesion, starting probably already behind the diagonal branch and really extending up to the proximal part of the distal LAD. It's a very long disease. It's challenging to say where it starts, so once again I would use my FFR-CT up front and point by point looking at the FFR measurements. But it's a long lesion with a beautiful landing zone for the surgeon. And then the circumflex, this is let's say the most clear lesion. This is a real Medina 111 bifurcation. And it's especially the angulation that worries me, regardless of which 10 technique I would use. It's challenging. So, in a conclusion, I'd say, and we decided upon all those results to plan a cabbage.
Very good. So, Johan Lemay, you are the radiologist. In the meantime, you have discovered these multi-slice CT scan and the FFR-CT. Is there anything that you would advise differently in the heart team, or you will have the same opinion?
So I agree. The FFR-CT confirms what we suspected on the angio. The RCA has no significant disease, in my opinion. And on the other hand, CT and FFR-CT also confirm the long lesions in the LAD and the severe bifurcation lesion on the CX and the OM. So, in conclusion, I completely agree with my colleagues.
Very good. So let's go to Milano, Monzino. Based this time on multi-slice CT scan, the heart team in Monzino has decided to proceed with cabbage. In a short statement, could you, Antonio Bartolini, the interventional cardiologist, on behalf of the heart team, give the key argument for going to surgery? It looks like in court here, but okay.
Well, I agree with the position of my interventional colleague from Brussels. from the clinical point of view, it is a patient with diabetes, chronic kidney disease. He has a very low ejection fraction. We have equipoise, but we have a difficult lesion to treat, especially on the circumflex artery. It is a quite tight Medina 111 bifurcation lesion, so to protect this peak obtuse marginal is a tricky business, because any technique that you use, provisional or two-stent approach, will have some difficulty, especially because of the tightness of the lesion and the takeoff of the branch that is almost 90 degrees going backward. The LAD is a long lesion, some calcification. There are 2 diagonal branches involved, although the ostium of these branches are not diseased. So you definitely need at least 2 stents, so there is the overlapping of the stents issue. I think that taking in consideration all the clinical aspects and the anatomical aspects, we are more inclined towards CABG in this patient.
Fine with me. So in the meantime, the radiologist Daniele Andreini has discovered the conventional angiography. What did you learn specifically from the cine angiography? You will say probably nothing, but it's up to you. But does it help to make your judgment?
Yes, thank you, Professor. So I think we saw that we have a very good agreement between CT and invasive angiography regarding left main, LAD, and circ assessment. On the contrary, as you saw, the invasive angiogram does not confirm the tight narrowing at the ostium of the right that was clearly visible on multi-slide CT images. And as you can see, without artifacts, without motion, without demargining artifacts, that may impair the evaluation, the non-invasive evaluation. However, at invasive angiography, the absence of this lesion is confirmed by the good bed flow of the contrast into the aortic root during the injection. So it's very interesting that, as Carlos has shown now, the FFR-CT is negative and exclude a flow-limiting effect of this lesion in agreement with the invasive anatomical evaluation. Therefore, I think that he would have been very useful in this case to compare CT images versus an invasive intravascular ultrasound in terms of anatomy and the functional FFR-CT data with the gold standard represented by the invasive FFR.
Very good, very good. So we are in a Congress of Interventional Cardiologists. Obviously, you are the winner today. Yeah, I mean, I don't know if the audience share the opinion of the heart team, but both of you, Giulio and Mark, first Giulio, what kind of difficulty are you anticipating in this case?
Well, thanks. For surgical standpoints, aortic calcification, as you can see here in the slide, have to be taken into consideration because they carry the risk of embolization after aortic close clamping. This is the first thing. So I think for this reason, I would recommend of pump surgery, which no-touch aorta strategy, with the white graft on LAD with the saphenous graft on the obtuse marginal in order to avoid this risk. And then off-pump surgery may also decrease the risk of acute kidney injury because this patient has a moderate renal insufficiency. And this is the second point to be taken into account.
Very good. So is the surgery in Brussels different from Monzino?
We just heard that you have been trained by the same master.
Oh, who was? Who was who?
Michel Duche from Montpellier, Belgium.
Good.
But what I want to, I agree absolutely. But also I think it's interesting to see the feedback from the room and the feedback from the heart team because there's no heart team in the room. They're only interventional cardiologists, and therefore the room is biased.
Very good point.
So
we agree with that.
So this is certainly, I think, the advantage of having a heart team, and therefore being able to decide together. And we would do the same. You can the right is to, let's say the lesion is not significant enough, so everything we put on the right will close within probably a week that we know. The circ distal circ is too small to put a bypass on, so I fully agree. I would do an up pump there for the CT, certainly an added value. We see all these calcifications. So an up pump, non-touch technique with a memory and then a wire graft to the vein.
Very good. So we are coming to an end on time, Keith and Martin, so that we are doing well. But let's use again the high tech, yeah? So we have now at the end of this session the question, are you going to use multi-slide CT scan and angiography in patients with already diagnosed CAD prior to PCI or CABG? The first is yes. So if it is yes, show the green board. I think we have convinced a very small number of people. And if it is no, I guess it's the rest of the room. Yeah. Now there is a sub-question which is selected case. Oh, that's good. It's selected case. Look at that. Oh, selected case is the great majority. So at least we have achieved something. Now to finish this session, I think that I have to say that for the last 18 months, what you have seen on the show is exactly what we are doing on Wednesday evening between 6:30 and 7:30 with the investigator. And indeed, these films are crossing the Atlantic during the night and being judged. And I must say, after it's a 40th anniversary, so after 40 years of PCI, I learned a lot from the multi-slide CT scan. And I can foresee that if we reconvene for the 50th anniversary of PCI, we may have more people in the room using multi-slide CT scan. Thank you very much.
I think that we can thank the two team for their very great job and very important comments. And so I think for this closing remark, we can, Patrick Sayers and his team can show you that it's in a complex diagnostic